a great segue to the next talk, which is how to maintain shock. And actually, Marwan arranged it so from the front lines of Mexico, we're going to the front lines of New Mexico now. Dr. Yo, who is a great colleague and collaborator, and we work together from the front lines of New Mexico to the front lines of Utah, right, Ray?
Yeah, yes. Thanks, Stavros. I've learned quite a lot in this session. I think this is just the beginning in shock care. I've actually trained here 11 years ago by Dr. Carr. I don't know if he's here, and thank you, Marwan, for inviting me. This has been a great conference. So my talk is about challenges faced maintaining a shock program. I put up these balloons because Stavros said he's coming in October, and we're going up in a balloon together in beautiful New Mexico. These are my disclosures. So if we did classic sky staging for about how stressed a healthcare system is, I think the most ranked, the best place right now is Nebraska, I guess. And if you talk about New Mexico, we're considered the most stressed state. I would say sky stage E, because we're practicing in rural America. Why is it really stressed? Well, 1 out of 5 people who are my patients live below the poverty line. It's the highest crime rate per capita, highest divorce rate. Life expectancy in patients living in rural areas are about 3 to 5 years less than in the majority of the country. We also have other socio-metabolic derangements. We're very anemic in healthcare. We have one of the largest nursing shortages in our country. A lot of our primary cares are leaving. And we're also considered the malpractice gold rush right now. Outside law agencies are actually eliciting lawsuits against physicians because there's very poor tort reform in my state. But if we talk about how we stratify level 1 shock centers, recently published by Dr. Shashank Sinha, well, we are considered a level 1 cardiogenic shock center. I only have 58 beds, 16 ICU beds, but we provide all full levels of care. We have performed 10 to 15 durable LVADs a year. We have ECMO, but there's only many of us compared to beds or health systems like Henry Ford or the Texas Medical Center, which is about almost 10,000 beds here. So when did I begin my shock journey? Well, I started this about in 2021. I saw the data presented by Tirani and those at Innova. Talked to my new, almost bestie in the shock world is Alex Truesdell. I go, is your data real? Did you guys really accomplish all of this? And then I said, I'm going to do it myself. And I said, yes, the data is very real. When I looked at my own data before starting this cardiogenic shock program, we were at 30%. All comers of cardiogenic shock. And every year, we got better and better. And I've actually had my best outcomes this year. We had over 161 shock cases, and now I have 75% survival. We're never, ever going to demonstrate a randomized control trial that this is real. You're going to have to prove it to yourself and your own administrators. But I'm going to tell you this is real. So this is my catchment area, kind of very similar to Stavros. These are all the patients that get transferred in my center, over 324 patients, with 45% of them coming from the outside of my city. So this is the 3rd year of my program. And this is not going to be discussed in articles, but this is what's really happening. So there's a constant, nurses are constantly leaving right now because of the shortages. Other states are paying higher in reimbursement. But my superstar APP, my cardiogenic shock coordinator, my APP, she covers 180 nights in the ICU. She's also my ECMO specialist. I am a ECMO interventional run program. We don't use perfusion. We don't have ECMO specialists. We just train everybody to take care of ECMO patients. She says, I'm leaving. I said, oh my God, I cannot do this program without you. Why are you leaving? She goes, things have changed. They're not fun anymore. I said, what do you mean not fun? We're putting all these MCS devices. You got to put swans at night. We're doing all these procedures. And then I said, name your price. I'll do anything. Stay, please stay. And she goes, well, I'm actually going to go to another hospital and take a pay cut. I said, what? You're going to be taking a pay cut? But we're doing all these great things. And what she really meant to say, or I said, give me some feedback. Why are you leaving? So it goes, I have no idea where this program is going. All I do is work. I get all these transfers. We're having all these problems. And what she really meant was there was no vision. You're right. In the first 6 months of developing this program, I had a timeline. Everything was laid out. We're going to do this. We're going to do this. We're going to do this. Now, starting to sustain a program, when people don't have vision, they perish. they don't have a goal anymore. And it's only work. And people get burned out. We were talking about ICU survivor guilt. I think that happens everywhere. And all of us see this, right? When you're having a lot of work, there's no vision. This is very important. So what's the vision? Like now, I said I'm going to commit to this. So what's my goal in the next 3 to 5 years? We see what Innova's doing. I look to Innova all the time as a classic, best example of best practices. So what they have decided to do is create local shock networks. And I myself, I'm going to have to create a local shock network because I cannot, in my small little hospital, accommodate these patients anymore. Other institutions around me, that's why it's so important that everyone starts developing a shock network. I don't have enough beds. I don't have enough resources to take care of these patients. And these patients need to go to other centers. So I'm starting to align with other institutions. I promise I'm going to elevate their shock program and teach them best practices from here. And that's why I'm talking to you guys here to discuss about best practices. I've learned so many things here. So the second point why she was leaving was there was so much drama. People are writing each other up. People are not following protocols. There's so much blame going around. And then what she meant was we have no core values. What are core values? Oh, well, if you talk to the hospital, oh, these are core values. They're on the poster. Respect each other, honesty, learn. And there's protocols, right? There's protocols how we should behave. People don't read those things in the halls of the hospital. How do core values get propagated to your team? Well, core values, what they really mean is how does work get done? How do people conduct themselves? And how decisions are made. And this is how functions of shock programs should exist. Well, first off, I've learned from Stavros, because I spent a week with him, is in the community, we do not have multidisciplinary rounds. We forget, hey, I have clinic, you take care of this. No, this patient is yours. So I've emphasized to the team is every morning we have AM shock rounds. This is where all the team members, I've learned this from Dr. Carr during a THI. We meet every morning and we go through every MCS patient. We determine the task of the day and then move on. And then what's the second most important component about managing a shock program? You have to have shock meetings every month. This is where business gets done. This is where protocols get derived. And this is where you perform your RCAs and your metrics. And these are some baseline clinical metrics that we go through. And this is the importance of shock. So the last thing is, what are values to the leaders of this field and things that you are willing to lose money over? So things that are non-negotiable in a cardiogenic shock program, I know we've emphasized this a lot, especially to our administrators, is CS coordinators, ECMO resources are non-negotiable. Losing my superstar APP who manages care is non-negotiable. And the administrators need to understand this, but they're not going to understand this concept until you show them data. So the data on maps, their survival curves, utilization, they have no idea what this is. But when you show them numbers, hey, these are our referral patterns. This is what's actually going on. They can do cost analysis. This is how administrators are going to understand the value of a cardiogenic shock coordinator. I know that's a frequent problem that I hear when we design these committees and these talks for these conferences, and the value of a cardiogenic shock coordinator. And on a happier note, we have leaders at SCI have been talking about this, finding about pathways or writing a consensus statement about the value of shock programs and the components and what the role of a CS coordinator is. So there's more to come in this field. Sorry, let me go back one. So in summary, like have a vision. If you're a leader in your shock program, have a vision when you reach your maximum growth. You're gonna hit I can't get any better outcomes than 75%. They'll never reach 100%. I've reached my capacity in my bed, so now it's time to rethink a different vision. And post-survivor shock clinics are definitely a pathway of care. And again, define your core values, what's important to you in your program, and the things that are non-negotiable are cardiogenic shock coordinators. Thank you.
Thank you so much, Ray, for this excellent presentation and the way you delivered it. Please.
Raymond, I just want to say I want to be like you when I grow up.
Did she stay?
Yes, she stayed because we made a blood oath. I said, if you leave, I leave. I said that. And if I leave, you leave. We made a blood oath. So I can't do my job without her.
Please, Phyllis, right?
Yeah, so great talk. Depending on where you practice, right, it depends on what that team looks like. So for us, core values, it really hits home. In Toronto, we actually, our ECMO patients, or VA ECMO patients, were actually being managed by our MSICU. which was 10 years of painstaking work of really building a relationship with that ICU colleagues and developing core values as a team and rounding. So it speaks to what we need to do no matter where you're practicing, no matter who's on your team, and building that vision together. So kudos to you, and I'd like to be you when I grow up as well.
Actually, I just want to be like my mentor, Dr. Carr. He's the one who's inspired me to do this. Thank you, Dr. Carr.
Excellent. Ray, we have a few more minutes for you.
Quick question, Ray, for you. I never learned how to put a business plan together in medical school, residency, or any of my fellowships. What advice do you give to providers? Who do we ally with? What's the most seamless way to kind of get this to talk to administrators?
So Cone Fisher, who's also on the paper when I wrote about Blueprint for Developing Cardiogenic Shock Program, is it's not as hard as you think. Number one, all you have to do is take your last MCS patient, Impella balloon pump. You tell them to do a financial cost review, EBITDA, on that patient. If you look at that, they're going to show a positive contribution margin. They're going to take the cost of the hospital. They have a full spreadsheet. They do this for every service line already, Watchman, all your different devices, all your structural. They know how to do this. It's just that when it's very hard to change an administrator's vision unless you show them numbers. You say, hey, do one on my MCS patient. It's going to be a positive contribution margin. I guarantee you it will, because I've had other practices do that. And when they look at it, they go, wow, this is, but it's also dependent on number, like how many patients go through your system. The larger the number of cohort of patients that go through your system, the higher the contribution margin. So that's how they think about it, and they know how to do it, or the savvy ones do. But it's not that hard, and they won't let me publish it, but I think Stavros has those numbers, and it's great that he had that article talking about the cost and benefit, and we really needed that analysis.
So Ray, that's great. What did you learn other than the volume? We just said the volume is one thing, which is going to help, right? What did you learn when they were looking at these numbers?
So when I asked them to start this shock program, I knew they weren't going to invest anything in it. So I had to become creative. That's why I said it's in a very stressed system. You can do this. But that person, so I give these shock talks around the country all the time. And I tell people, how many people are able to actually cross over that threshold and develop a shock program? Because we all have that similar challenges. It takes that one champion that says, I'm going to do this no matter what and not sacrifice my values, but become very creative in it. So if I could do it in my very taxed system and demonstrate to them and just win their minds and hearts, it's feasible. And you have to show them the wins. You have to show them survival. You have to show them the practices of other programs like mine. We started at 30% survival, now we're at 75% survival. And that's a lot of lives saved.
You know,
James.
I think your contribution margin comment is critical. I think the other one that's a little softer but still there too is the CMI. When you increase the CMI of your patient population, you increase to a degree the Medicare reimbursement. So that's another key figure. And these critically ill patients help do that significantly.
So you almost lost that coordinator because she didn't have the same vision that you have it at some point. So there is a book that is called Start with Why, Simon Sinek. And he said that there is three things: the why, the how, and the what. So you're showing the what always. It's like, oh, my outcome, this is improved. That's what you show to your hospital administrator. The how is the process, but you know the why is really the message. It's your vision, and you need to surround the people that have the same vision that you. It's like when they made the comment that there were nurses or people saying like, oh, what are we doing here? You know, they don't know that they have saved people, that if you don't intervene, they have died. Even some of them that has not the best quality of life, but there was a proportion of that population that did get saved, went home, and they were perfectly functional. And you know, you always have to share your vision.
And along these lines, we never need to forget that instead of just giving great talks around, sometimes we forget to give the talk in our own hospital and in our own team, because we think that we take it for granted that everybody's on the same page all the time, but as you showed, it's not.
Yes, absolutely. It's actually coming up on my 3rd year anniversary. We call it a shock anniversary. We normally bring a survivor in our shock program in to thank the ICU because they love it, and that's what brings our mission like really meaningful, is showing our wins and sharing our losses. This is like the shock community. We're all shock doctors, and we all need this.
Excellent. Well, thank you so much, Ray. We need to move on.